We are live now.
Respected seniors and dear friends, good evening and welcome you all to this Tuesday Tea Time Learn Simply with Dr. Kawita Bapat. I'm Dr. Jyoti Karande, Secretary of Indore Obs Gynae Society, and it's my proud privilege to introduce Dr. Kawita Bapat, Madam. Indore Society has seen her glorious journey from President of Indore Society, conducting various vaginal surgery workshops and her publications, Press Committee Chairperson, and then Vice President of Foxy. I think all this is possible because she believes that a glorious journey begins with a bright vision. She also believes that there should be a good clinical governance, there should be standardization of clinical practice, there should be upskilling of doctors to various training programs, and also every unreached should be reached through Foxy. And above all, what we all feel for her is that she believes that every member matters. I welcome Dr. Kawita Bapat, Madam, to conduct this.
Thank you so much. Thank you so much. Thank you so much. Can you put the share the CV of Dr. Shekharan, sir, and so that I can start. So, good evening, everyone. Tuesday Tea Time Learn Simply with Kawita Bapat is a platform of conversation, insights, and knowledge sharing, and the take work messages. Especially, we have a crisp knowledge about the various subjects through conversation with leaders and experts in their respective field. Our goal is to provide a practicing OBGYN to assess a valuable information, knowledge that can they use and they use it and they grow professionally and personally. Today, I'm really proud today that I have a very, very senior OBGYN, Dr. P.K. Shekharan, and who has made a significant contribution into the field of OBGYN, particularly in the area of gestational trophoblastic diseases, and his accomplished roles of the various organizations is truly commendable. As a president of Kerala OBGYN Society from 2003 to 2004, he demonstrated a strong leadership and played a vital role in advancing the field with the region. His commitment and dedication to provision are evident. His role as a vice president Foxy in 2010 was undoubtedly contributed the growth and the development of the organization. His involvement as an organizing chairperson for 25th World Congress of GTD Insights has ability to manage and coordinate large scales of events, and this Congress provided a platform of the experts and professionals around the world to exchange the knowledge. His appointment as a secretary treasurer of the International Society Study of GTD from 2013 and 17 demonstrated his active involvement in the international organization. His position allowed him to be significantly in the society objectives, further the understanding and the management of the GTD on the globe. Additionally, he is a co-author of FIGO guidelines in the management and further showcase expertise the influence in these fields in so many times. Furthermore, he has 51 publications, 407 citations, indicate his research productivity and impact of scientific community. So overall, very impressive contributions, achievements in the field of OBGYN, especially his involvement in the GTD research, leadership roles, guidelines development, and publications. I am really proud to have you, sir, today, and we are going to have a dialogue on the prevention, on how we are doing the prevention into the preeclampsia and how it has to be done. So over to you, sir, for just an opening remarks, and then we'll have simple 10 questions that will be crisp one, and then you are going to answer. We'll finish the program in 30 minutes. That's our promise to our audience. And I think over to you, sir, for just prevention and prediction of preeclampsia is today's topic of discussion between you and me. Such just opening remarks, and then we can start the questions. Thank you so much, sir. Over to you.
Thank you, Dr. Kawita. Thank you, Dr. Kawita, for your wonderful appraisal of myself, which I don't know myself so much. And thank you very much for the opportunity and wish you all the best. Preeclampsia is one of the very, very important complications that we see in pregnant women. And unfortunately, still it is claiming so many lives. All over the globe, almost 50,000 women are dying every year.
Yes.
And almost 500,000 children are also, babies are also dying because of this. Moreover, this complication, if somebody develops, is going to have some more problem later on in life, like cardiovascular diseases, and other complications like other complications that may lead on to the reduced lifespan of the individual as such. And that is more this thing, not only the during pregnancy and its complication, but later in life also. So that is in a nutshell, what are the implications of the disease. And that is the second leading cause of maternal mortality nowadays in India. As I have studied both the series, it is one of the second leading cause of maternal mortality in our country, in our state also.
Yes.
So that's the problem that you have to see.
Yeah, so it's nice, sir. Being a senior OBGYN of the state Kerala, where the maternal mortality has gone so much down, I think all your people have efforts, what the research you have done, what the publications, what you've done, what the work you have done at the root level that has made the reduction in by means of the overall working of all the OBGYN that state has done. But I'm sure that you will like to tell about the prediction and prevention of preeclampsia and how you are coping up at your state, as well as what should be the take-home message for all over India. So, we all know what the preeclampsia, how it is to be prevented, and the risk factors. I think most of us know, but if you would like to add some risk factors which are very, very important for preeclampsia, we'd like to know about.
We have to anticipate when a pregnant woman comes that she is having any risk from the history itself, whether she had any preeclampsia previously or she is carrying a twin pregnancy, if she had conceived after IVF pregnancy, if she is obese, if her parent or mother had preeclampsia, sister had preeclampsia. These are known to us. But what we are trying to impress upon our colleagues is that history may pick up only about 10-20% of the cases that may go into preeclampsia in the present pregnancy. So there is an impressive and proven prediction method as reported by Nicholas and other, the fetal medicine man, and they have done extensive research and studies, and it has been proven that this method of prediction of preeclampsia in the first trimester, not when they develop the complicated trimester. There is an opportunity when she comes 12 weeks, a method of maternal history, a well-taken mean arterial pressure, and then a Doppler study if possible of the uterine artery particulate index at 12 weeks plus, and also biochemical analysis will predict early preeclampsia, which is the most dangerous one, where you have to terminate pregnancy at least by 34 weeks. That is the early ones. And those type of preeclampsia can be picked up. At least 80% of the cases can be picked up by this method. As we said, this is the second cause of maternal mortality.
Yes.
Prediction is not going to have any influence unless you have something to prevent it. So here is a model where you can predict very much in the first trimester. And there is a tendency for our colleagues that just to start aspirin for each and everyone. That is not correct. Aspirin is having some problem also. Don't give any medication to pregnant women just like that. So it is only about 10% of the people may be predicted to have preeclampsia by this screening method, which can be combined with your aneuploid screening. If you can't do it, at least offer this, because people are more and more aware of these complications, and something happens, they can turn around and ask you, why didn't you do this screen for my baby now is down, which could have been prevented. So it is their choice. So offer them that there is a method of screening for preeclampsia in the first trimester, and that is possible to predict at least, if not 80, at least 50% of them can be predicted. That is, and prevented. That is the importance. So we all know that, the first trimester is the concentration now is on the first trimester. We screen for aneuploidy, we screen for diabetes, we screen for anemia, we screen for thyroid, hypothyroidism. Everything is concentrated on the first trimester, which is now termed as the inverted pyramid of antenatal care, because we were concentrating on the later weeks where complications occur. Now the concentration or care is on the first trimester, where you can predict and then try to prevent, or at least strategy should be evolved to treat this patient more frequently and leave the others for a less frequent visit. Not that everybody coming every week in the third trimester. You concentrate on a group and prioritize those group to get. So if you want more on this prediction model, it is well tried. And well tried in 60,000 people in one study, in another study 30,000 pregnant, and it is all world over. This research is going on, and the thing is that when you are doing the aneuploid screening, when you are going for the MT scan for the aneuploid screening, have another 2 minutes to see the uterine pulsatility index.
Exactly.
If you are not able to do the biochemical thing, even then, it is worthwhile to see the proper history you have to take, where it is important for any obstetrician to take the history, maternal history, her weight, height, and BMI, what is her family history, anything, what is her race.
Yes.
So all those things are to be fed on to a simple software which is available free on internet. You can just try Fetal Medicine Foundation preeclampsia screening. The form will come. Just fill it and click it. That will give the risk scoring will be given.
Amazing. Amazing. So, preventing regular prenatal checkups is number 1 point. Another is a blood pressure monitoring is another important point. And so you have already talked about the history, which is very, very important to be taken. And with the prenatal screening, we should go and see for the uterine, the artery flow and everything. So important these all points are, because we know if not preventing the preeclampsia at the right time, this can lead to slow growth, preterm birth, low birth weight, and so many things can oppose upon this. And sometimes a female can end up in a damaged stroke or severe cases and maternal deaths also. So, but another the important thing which I always feel about this thing, any specific patient asks that how we are preventing anemia, preventing preeclampsia by some dietary advices, or you can say any medical advices, medicine which you have to prevent, when to give the medication, when to start the medication, and when to stop the medication. And these are the 2 questions which comes in our mind. We do the regular checkup, but should we have to insist ourselves on talking about the physical activity, medications, and the diet part? These 3 questions together I am putting, sir, in a simple manner. By these 3 things, how can we reduce it, prevent the,
Okay. Before going to that, if you think that the biochemical estimation, other plasma growth factor and the uterine daughter is not possible, please take the proper history. Please record the mean arterial pressure with a calibrated BP apparatus. Then at least feed onto this form. That will give prediction. Not just somebody had in the family had preeclampsia, may not be the correct way, but give that. So that is the first thing. Once you see a risk which is given by this immediately, if the risk score is 1 above, that patient is qualified to be called as a more risky for developing. She may not develop, but they come through. So if you screen a population of India and anywhere in the world, only 10% may be picked up as probably going for treatment. That's it. Then your question of medications and dietary supplementation. In the diet, what we have to remember is no restriction of salt. That is something which we were, earlier somebody was correcting. So there is no restricting salt. There is no benefit of taking vitamin E, vitamin C, and other things.
Yes.
There is no role of nitric acid donates like arginine and other things. There is no role as per the study. Only thing what is required is a calcium supplementation of 1.2 gram may be beneficial to prevent.
Yes.
And then physical activity as usual, there's nothing specific she can have. So physical activity, but the lifestyle modification of reducing the weight, pre-pregnant weight, pre-pregnant hypertension if she is already having chronic hypertension, pre-pregnant control of diabetes. So these things are possible in the prenatal visit if something is available. But they have to be careful to control this lifestyle diseases to prevent the onset of preeclampsia in the late life. So that is on the diet drugs like progesterone or even low molecular weight heparin are not having any place in prevention. So when you see that there is a risk for a more than 100, these patients are to be started on low dose aspirin. Low dose is not 75 milligram, but it should be at least 100 milligram, if not 150. Recommended dose of the aspirin every day it has to be given at bedtime is 150 milligram.
Yeah.
And at least also shown that at least it should be 100 milligram, not 75 may not be effective. So
Yes.
that is one drug that we can give safely and to be given every day till 36 weeks of pregnancy or earlier once she develops preeclampsia or she develops or when she has to be delivered. So
Yes.
it is only up to 36 weeks because there can be some harmful effects, but it's safe. We have seen it is safe by various studies. So effective dose for this condition to prevention is up to 80% is possible as per their study of early onset preeclampsia, which is more dangerous. And in low resources countries, the early onset preeclampsia is more dangerous and that is going to kill the mother as well as the baby. And there the prevention is said to be up to 80%, which is a huge number of reduction and the complication of many important causes of maternal and perinatal morbidity and mortality. So this is such a simple thing. Even if you just feed this history and the properly taken BP and the height, weight, and all other details, all those things are given in that format, and you will get a risk scoring. And if you start aspirin, simple measure like aspirin, only at least 50% of this complication can be prevented, which means we can reduce at 50% of the maternal mortality and perinatal mortality. Such a simple thing. But it's not right to start aspirin for every pregnant woman. It's not warranted.
Yeah.
It's not correct. It's not scientifically correct to give any medication during pregnancy just because it may. So you have to select by simple means. So that is the prediction. And prevention model they have shown extensively in the study world over they want to reduce the incidence of preeclampsia. And that is such a simple procedure. Why can't we employ it? Even if you are not able to say the biochemical estimation of placenta growth factor, the urinary study, please take the proper history and the mean arterial pressure, feed onto this software which is available online and calculate the risk and then give. Then the early treatment of hypertension is most important. Don't ignore a low level of hypertension also, even if it is just above 140/90, which is hypertension in pregnancy. As per the International Society for Study of Hypertension in Pregnancy, a level of 140/9 and above is hypertension. Now, preeclampsia is hypertension with proteinuria, but it is not essential to have the proteinuria to make a diagnosis of preeclampsia now. As per present knowledge, preeclampsia can be hypertension, which is 140/90 and above, with the proteinuria and or any evidence of end-organ damage like kidney, liver, brain, or the platelet count going down 1.5 lakhs and below, or there is Doppler changes on the fetal placental study, the Doppler study showing up-down Doppler flow, or intrauterine growth restriction, or fetal demise during pregnancy. Everything is now grouped as preeclampsia. It's not essential to have the proteinuria with the protein. All these things are also taken. That latest thing that we may have to run at international level, which is coming, and we are to know all those things. And mortality, as you said, prematurity and fetal loss, because we may have to feel sometimes because of the severity of the preeclampsia going for so many complications like HELP syndrome, which is a very dangerous complication. And in our series of maternal deaths, unfortunately, 50% of the patient died with preeclampsia in such series. That was the inadequate care given during pregnancy after detection of preeclampsia, and also timely was not done. And also the dosage of medication it should be carefully done.
So nice, sir. You have put all the points so together, but only two questions which is come into my mind. That this is a really important subject because we don't want that our patient should die because of the eclampsia or preeclampsia. So do you think any genetic component in the preeclampsia? This is the first question which comes into my mind. And the another one is, what are the ongoing researches or the advances in the field of prevention of preeclampsia? Like you already talked about all the subjects, all the topics with the mean arterial pressure, the giving the aspirin, when to start, what are the warning signs, what is the prediction. But these two things are very important. Are we doing a genetic component for the preeclampsia? Can we predict by doing some genetics testing? And another thing, what ongoing research which we can think about and we can help our patients to do it. This will be the concluding question, sir, for today. Yeah. Over to you, sir.
The genetic background is there, but it's very difficult to pinpoint because it's a heterogeneous group of genetic deviations are seen in preeclampsia cases. It's not one simple gene.
Yeah.
So that is where the researches are going on.
Yeah.
Many genes are identified, like ENOS gene, that's nitric oxide that oxidant. That is one gene discovered. So there are several genes connected to preeclampsia, and that's why there is a familial predisposition also. The sisters having it and mother and daughter have. So that shows it's a genetic, but we are not able to make any breakthrough on that level.
Yeah.
The other research now people are concentrating on, because it is a well-established system of prediction and such a simple mechanism of prevention. People are now studying more and more. Even from India also there is a contribution. And only problem when to start with 150 milligram. That was our problem when we started in a two situation. We tried the study into groups, and our fear was whether we can start with 150 milligram. We don't have the 100 milligram nor the 50 milligram to give it. So that was our dilemma. So in both the studies done as a thesis for our students, the outcome was not very clear because we used only 75 because of fear, and it is not approved like that. Even it is not approved by FDA so far. So things are like that. On that, whether we can jump on to such a situation is the, but the studies and the result has been shown that it is safe. It should be stopped by 36 weeks if not she has to be delivered earlier. So that is the present status. Everybody is concentrating on this sort of a prevention which is propagated by the Peter Medicine Foundation, and Nicholas is on it, and they have given so many lectures and other things, and it's all worthwhile. Probably it is all available online, and that is where it is going on. But the research is on to the placental site, I mean placenta. Why it is happening to some people. So there are so many molecules identified, including the placental growth factor, the SFLT, that is another molecule. So all those things are being studied, and also the monitoring of the preeclampsia by this ratio of the SFLT and PLBS is also being studied, ruling in preeclampsia. All those things are coming. These molecules are important in the angiogenesis and prevention of the growth restriction. So growth restriction also, this is one of the etiological factors, the placenta. The early development of placenta, as we know, is not being remodeled. Absence of remodeling of the viral artery, basically. Why it is happening? There is genetics, as well as these molecules are also, the angiogenic and anti-angiogenic factors are having a role in this thing and also producing the disease. It has been said that there is a placenta stage of the disease and there is a maternal stage of the disease. Yes. Placenta stage one, which produces the growth restriction and hypertension, and later on the mother develops all the complications. So it is the same simple one and the same program which is going on. So
yes.
The future.
Amazing, sir. You have put all the points so nicely. I'm really happy that basically all the ongoing research, studies, and advancement in the field of preeclampsia, what I feel also, and you talked in such a nice manner. Number one is the biomarkers. They should work on the genetic factors. As you have suggested, it's not the single gene thing so that we can diagnose it in a single man, but still there is a studies and a research and a hope to develop the screening methods and personalized interventions. And then the predictive models, which you have talked about, all the models, which are very important. That's maternal age, history, the biomarker level, and correlating all those things in a likelihood of developing the preeclampsia, and the management and intervention, which you have talked about, all the studies of aspirin, the calcium, and this additional medicines are there. And placental research, I think this is a really important thing, and because they have to be controlled studies should be there, and that should be structure, the function, the blood supply, how the valuable insights for the preeclampsia about the pathophysiology, very, very important. So thank you so much, sir, for being with me. This is a crisp program of 30 minutes, only 10 questions or something like that. I'm so thankful that you being with me today for the prediction and the prevention of the preeclampsia. This is a really a crucial topic, and this is one more important factor in the reducing maternal mortality of this India, how to prevent it. So thank you, sir, for being with me. This is a tea time, and I hope our recording of this will be helpful to the general practitioners and those who are listening to us. Thank you so much, sir.